Good evening, everyone, and thank you for joining tonight. Welcome to the Brews and Views at-home edition. I'm Chris Kontag. I'm the director for the Institute for Quantitative Health Science and Engineering, and I want to reach a special thanks out to all of our alumni who are joining tonight. It's great to have you with us on the at-home edition of Brews and Views. We're broadcasting from Michigan State University, and Brews and Views was started by the Institute for Quantitative Health Science and Engineering, along with the Center for Ethics in the Humanities and Life Sciences. We started this for the purpose of discussing scientific and social impacts of cutting-edge biomedical research, and this is a continuation of that series. Since March, we've been focusing these discussions on COVID-19 and have aimed really to bring information from regional experts to the greater MSU community and now to the alumni university. And we would like to discuss some of the most pressing health issues that we face today, and this at-home edition has really focused on COVID-19, and we bring together a team of panelists who can address multiple aspects of COVID-19 as an important health problem. Tonight, we're going to focus on COVID-19 immunity, and as the nation's first land-grant university, problems like this are what Michigan State should be focusing on. We have representatives from the Center for Ethics and from the Institute for Quantitative Health Science and Engineering on the call tonight, and I'd like to introduce them quickly. Heather, if you would introduce yourself.
Hi, everybody. Thanks for joining. I'm Heather Hazard. I'm the Chief of Staff at the Institute for Quantitative Health Science and Engineering, and I'm a member of the Brews and Views Planning Committee.
Sonia, would you introduce yourself?
Hi, everyone. Nice to have you on today. I'm Sonia, and I work in communications for the Institute for Quantitative Health Science and Engineering.
And Libby, would you introduce the folks from the Center for Ethics?
Sure thing. I'm Libby Bogdan-Lovis, Assistant Director at the Center for Ethics and Humanities in the Life Sciences and part of the Planning Committee. And I'm joined today by my colleagues, Dr. Karen Kelly-Blake. Karen, you want to introduce yourself?
Yes, thank you, Libby. I am Karen Kelly-Blake. I'm an Associate Professor in the Center for Ethics, the Department of Medicine here in the College of Human Medicine. And I am part of the Planning Committee for Brews and Views.
And Dr. Laura Cabrera.
Hi, everyone. Thank you for joining. I'm Laura Cabrera, Assistant Professor of Neuroethics at the Center for Ethics. Happy to have you here. Hope you enjoy it.
Great, thank you. For this evening's discussion, we've asked Professor Mark Largent to moderate this session. Mark is the Associate Provost for Undergraduate Education and the Dean of Undergraduate Studies at Michigan State University. Thank you, Mark, and I'll turn now over the Brews and Views at-home edition to you. Thank you so much for hosting tonight.
You bet. Thank you for the invitation. I really appreciate it. These issues are very interesting and important to me. My work background focuses on the history of medicine and on the history of vaccine uptake and concerns about vaccine safety. So it's certainly relevant to my professional interests, but also to my current job as Associate Provost and Dean of Undergraduate Education. As at Michigan State, we had made the pivot to remote teaching and have shut down all the residence halls for students. So issues about immunity and about differential impact on communities of the virus and potentially of a vaccine are both professionally and in terms of my current job very much in the front of my mind. So I appreciate my colleagues joining me this evening for this conversation, and what we really want to do is just sort of interrogate the issue, explore what kinds of relevant issues there are and underlying science that motivates some of our understandings, as well as some of the deeper background issues that help us think about the impact of the virus and a potential vaccine on a host of social, economic, and cultural issues. In the flyer, we asserted that we wanted to describe what's known about immunity to the virus that causes COVID-19. We want to review some of the vaccine strategies that might lead to protective immunity. And we'd like to discuss the rights and responsibilities of individuals who may be susceptible to the virus, who may carry the virus, and who may have immunity to the virus. So we've asked four different people to join us tonight. And I think the backgrounds they bring to this conversation demonstrate why it is that land-grant universities like Michigan State University are particularly well placed to deal with really complicated problems like this. So let me, in alphabetical order, introduce my four colleagues. First, I'll introduce Christina Boyles from the Digital Humanities, Department of Writing, Rhetoric, and American Cultures. Ask Christina to introduce herself and her background a little bit.
Hi, yes, I'm an assistant professor of culturally engaged digital humanities here at MSU with specialties in data ethics and surveillance. And I'm going to be talking to you about humanities approaches to COVID and vaccination. And I'm looking forward to chatting with you tonight.
Thanks, Christina. I'm really happy to have you here. We also have Deborah Verholden from the Department of Epidemiology and Biostatistics. Deborah?
Hi, I'm Deborah Verholden. I'm also the Director of the Division of Public Health and the Associate Dean for Public Health Integration in the College of Human Medicine. I'm an epidemiologist by training, and most of my work is focused on health equity. Thanks for having me, Mark.
Yeah, I'm happy you're here, Deborah. We have Andrew Olive from the Department of Microbiology and Molecular Genetics. Andrew?
Thanks, Mark. As he said, I'm Andrew Olive. I'm an assistant professor in the Microbiology and Molecular Genetics Department. My research interests really center around understanding interactions between pathogens and their host. We really focus on three major questions, which is how do pathogens cause disease? How can our host response actually protect against these pathogens? And how can we devise new therapies such as vaccinations to control these infections? And so I'm happy to dig into this. My expertise spans many different pathogens, in particular persistent pathogens like Mycobacterium tuberculosis. And I'm excited to chat about any of these types of topics tonight.
All right, well, welcome, Andrew. And we have Nigel Paneth. Nigel is from the Department of Epidemiology and Biostatistics. Welcome, Nigel. We are not hearing you, Nigel. I'm sorry.
Nigel's having a couple issues right now. We're working on it, so we might have to come back to him later.
All right, I promise we will. Nigel.
Hello, how's this?
Oh, we can hear you now. Go ahead.
Well, I got a message to press some buttons, and I pressed those buttons. I'm Nigel Paneth. I'm a professor of epidemiology and biostatistics, like my colleague Deborah, and I'm also a professor of pediatrics and human development. And my contribution here consists probably mostly from my, not so much my work as an epidemiologist in general, but because I've been part of the national COVID-19 convalescent plasma project, and obviously the use of convalescent plasma speaks to a lot of antibody issues. So I can perhaps tell you some of that experience today.
Thank you, Nigel. I'm happy you're here. We have got a lot of ground to cover. We have about 2 hours to do it. While I've introduced these four colleagues, the fact is that a lot of this conversation is going to be driven from questions that arise from the now 116 of you who have joined us this evening. We would be 117. We'd be very happy to have you use the Q&A function on Zoom to add questions in. If you see a question that you like, upvote them. Oh no, I'm sorry, only hosts and panelists can see the questions. So go ahead and put the questions in. We will keep track of them. I've got a host of colleagues here helping shape these and put the ones sort of forward that we need. So we can start exploring this issue from a number of different angles. It's cultural impact, the politics and healthcare, epidemiology issues. I think we'll start at the absolute smallest. Let's actually start by talking a little bit about the virus itself, what we know about it, what we know about things that are like it, what the background science on it is, and then try and build from there. So let me turn first to Andrew. Andrew, recognizing that we've got an audience of both specialists and lay people, people whose focus is on bioethics or on the sciences, give us a general but well-informed description of exactly what the deal is with this novel coronavirus, why it's problematic, its novelness, its novelty, and help us understand what some of the potential directions are for responding to it with a vaccine.
Yeah, I mean, there's a lot to unpack in those several questions. You know, I'll sort of start by maybe underlying just the pathogenesis of COVID and why it seems to be so problematic. And a lot of it really has to do with how pathogens cause disease and how our host response actually responds to them. And really, your immune response happens in 3 phases, where you get an infection, your host response needs to first detect that infection. It then needs to signal help to other cells to come eradicate that infection. And then these other cells come along and try to kill the cells that the virus is replicating in, or use antibodies to bind up chunks of that virus and clear it from your body. Now, some of the problems with COVID is, one, it's a novel coronavirus, which means there's no underlying immunity against this virus in the first place. And we could sort of talk about what immunity actually is, and I'm sure we'll get there in this conversation. But I think one of the first things that's problematic with COVID is that it really disrupts that first step of your immune response. It seems to be unable to be detected by sort of your innate immune response that helps start off these infections. And the problem with that is it allows this virus to really gain a foothold and start replicating and cause disease faster, and it delays all the subsequent steps of the immune response. The other thing that's problematic about COVID is that it causes really robust inflammation. So anytime you have an infection, you have these proteins called cytokines that are supposed to signal and recruit other cells, and those cause a number of things. Now, the problem is if you have too much inflammation, you not only are trying to kill the virus, but that inflammation can also do damage to your own body. And with COVID, that seems to be a really big problem, is that because you have this delayed response, you have a lot of inflammation, and some people, particularly if you're susceptible, you have underlying health conditions, or you're older and aren't able to deal with that inflammation, it can cause really serious lung damage that you really can't recover from very easily like you do from other infections. And so sort of all of those things together sort of equal a really dangerous pathogen where there's no sort of pre-protection in the population. It has really good mechanisms that it uses to try to avoid your normal host responses. And then your immune response just seems to be really exuberant to try to clear this virus, which then causes a number of other sort of problems downstream.
So the novelty of it, along with just the nature of it, despite its novelty, seems to combine to create a host of problems for us as its hosts. So let me turn that to now to think about it, not as thinking about the subject, not as the virus, but as patients. So when someone contracts this, we're seeing radically differential impacts of the virus and the host response. And what's intriguing about it, if you can get enough emotional distance from it, is that it seems to also exploit a number of the differences that we have among ourselves as citizens. So let me turn to Deborah for a moment and try and understand that. We do not see this virus impacting communities. We'll just focus on the United States for now. It's not an even distribution. So we know socioeconomic status, race, age, and even to a certain degree gender all seem to result in very differential symptoms, morbidity, and mortality. Deborah, can you unpack why it seems to result in that? Is it the nature of the virus or the nature of us?
So real quick, it just started like a monster rainstorm where I am. And my granddog is here and she was going nuts. So we've sort of, and I worry every time this happens, my internet goes out. So I just wanted to give that caveat. I'm in Flint. So I think it's a two-part thing. So there is something about us, right? Because disparities predated COVID. And so what we saw in COVID typically follows other disease trends, whether we're talking about chronic diseases or infectious diseases. I think specifically the super hard hit that we saw in African-American communities, and now we're, finding data around Latinx, looking at the data in Latinx communities and Native American communities. I think the thing that we realize is a lot of the vulnerability in those groups are highly correlated with COVID. So if you are African-American, you're less likely to have health insurance. you're more likely to work in a high demand, low pay job. And, we now realize with so many people losing jobs in insurance, oftentimes insurance is linked to employment and things like that. And so I think it's this confluence of factors, because unfortunately race and class and vulnerability are collapsed. And there are other socially vulnerable populations that aren't racial ethnic minorities. But I think that's a big part of why we see what we see with the racial disparities around COVID.
All right, so Nigel, let me turn to you for a moment and ask about some of our response to it. So we've got the viruses, our body's response to the virus. We have a broader social disproportionate impact among different groups of people. Let's talk for a moment from the individual patient point of view. What responses have we tried to develop over the last 6 months, and where do things stand in terms of not preventing this, but treating it once it's contracted?
Always our first line of defense against almost every infectious disease is to prevent exposure. And we can't forget how important it is to try to minimize the risk of just simply being exposed. And a great deal, generally infectious disease, a great proportion of the higher risk in communities that have been discriminated against or have had unfortunate social circumstance is the risk of exposure is increased. You and I may take a car to work, but a poorer person may have to take a bus. You and I can stay home to work, a poorer person may have to go into a crowded area to work. So the opportunity for exposure is so often enhanced. And then you say, given exposure, how likely you are to get sick. And we know a whole host of factors that lead to that, some of which are overrepresented also in poor communities, such as diabetes or hypertension and such. The biggest risk factor, everybody knows this, is age. And I sometimes say, I've been very busy as an epidemiologist in this epidemic, and thankfully not so busy as a pediatrician, because children have been less affected. And that's a very nice thing, because in the 1918 flu, some may remember, it was young adults who took it, hard. In terms of treatments, we've scrambled. As you know, there was a passion for hydroxychloroquine, the anti-malarial drug. Even, frankly, and it surprised me very much, even before the presidential backing, there was a substantial use of it around the country. In the Mayo Clinic database that we've assembled of convalescent plasma users, in the months of May and April, in March and April, 60% of everybody in our data system had received hydroxychloroquine. The figure for August is 3%. I've rarely seen a medication disappear from the medical field quite as rapidly as this one, but 5 negative randomized trials will do that to you. So we went through our hydroxychloroquine fantasy, that's gone. And even though you may remember, it was actually emergency approved by the FDA, which was then revoked. Then comes remdesivir, of which there is a pretty solid trial. I have to say pretty solid because it's not the most convincing trial ever mounted, but it's not a bad trial. And it does show some evidence of effectiveness, a modest reduction in mortality. It was not significant. And some other good things about it. And if subsets of the data of not very sick people, actually there was a really quite remarkable decline in mortality. So perhaps it's valuable. That has received emergency approval. So remdesivir is available. Steroids have been mentioned. Steroids are particularly effective, unlike remdesivir, and I'll come to convalescent plasma in a moment, in the more advanced stages of the disease, the people who are sicker for the reasons Andrew gave. The steroids are effective in fighting the hyperimmune response, the cytokine storm part of it, which is a feature of the more advanced or severe illness, not of the early illness. Other than that, we don't have anything really clear. There's some antibiotics that have some evidence of effectiveness. There's a monoclonal antibody that is a little uncertain too. The big news has been last week, convalescent plasma, as some of you know. It's had this fascinating history, both in terms of its overall use for many one of the oldest therapies available to us in modern medicine, and because it's become a bit of a political football. I'm of the view that it is probably effective, certainly safe, effective enough to, and I've publicly in the media I've stated this, is sufficient. I think the evidence is sufficient for the FDA to have authorized emergency inpatient use. That's the only authorization. Not full authorization as you would for a drug that's been through many trials, but we can talk in detail about it. That's one option. And I think that and remdesivir and steroids perhaps are the only three pharmaceutical options we're aware of. There are other options involving medical management, positioning, use of ventilators, non-use of ventilators, continuous positive airway pressure that I won't get into. But there are people probably here much more qualified to talk about than I am.
So this is not a solved problem for us, neither the cause of it nor the treatment of it. Its novelty seems to hit us very hard, but one thing, and Christina and my background disciplinarily is similar enough, there's an awful lot of things that I have seen over the last 6 months, Christina, that looks awfully familiar to me. And you know, the old line, the people who don't study history are doomed to repeat it. People who do study history know that we are doomed to repeat it. Christina, what have you seen from the introduction of this virus to our community through to today? So really the last 6 months, that looks frighteningly familiar to you.
Well, some of the things I want to talk about are the ways in which we're handling data and then that effect on communities and on real people and our response mechanisms. So working from a humanities approach to data, what I look for are the things that we're missing in our current collection, calculation, or dissemination practices. And I can give a good example of that. So we're about to start the fall semester, and a lot of us send introductory emails to our students asking them what they need to make sure they're successful this semester. Say you did that in a Google form. Well, you might actually have a handful of problems. We know that some of our students who are participating internationally won't have access to Google, and so they'll be left out of participating in this system. And the problem with this is that if you're the instructor, you might not realize this. You might think, I've collected a lot of great data and I've designed a course that's going to meet the needs of all the students who've responded. And so that missing piece, that part that the person might not even realize is not being calculated into their decisions, that's called the surveillance gap. And that's a term that's been coined by Gilman and Green, two lawyers who work on this issue. And they note that the surveillance gap can describe the experiences of a lot of different people, many of who Deborah mentioned and many who Mark referred to, groups that have been historically marginalized because they are itinerant, they live in multifamily households, they live on reservations, they're migrant workers, and so the way that we perceive of their data doesn't necessarily fit all of our structures. And so the surveillance gap, I've seen it play out with coronavirus in two concerning ways. And the first is that we're just missing some data. If you look at death toll counts right now in the US, our official count is roughly about 180,000. But if you compare number of deaths in 2020 in the United States to that of previous years, the number is closer to about 230,000, which means we're missing about 50,000 deaths. And for someone like me, this is what is most important to focus on, because these are the people we're failing to count, the people we can't account for, and who we need to take into consideration as we're developing responses. And this could take a variety of formats. So these individuals could represent those who had coronavirus but didn't have access to medical facilities, people who experienced heart attacks or strokes or other complications from coronavirus and it was recorded as that kind of last final medical event, or people who were fearful to go into medical facilities because they had existing chronic conditions or a sudden emergency, but they were concerned that they might contract coronavirus and so they stayed away. So we have that, the layer of people we miss. But the second thing we have is we have the people who are unmotivated, let's put it that way, to participate because data collection is in its essence, or can be, a form of policing. I'll give you an example of that. I had a colleague who asked students at the University of Louisville if they would share whether or not they contracted COVID with the university. And roughly about a third of them said no. And every single one of those students said fear of retribution was their greatest reason for not reporting. And this took a few different forms. Some of them thought they'd lose social status, that their reputation would be tarnished. Some of them thought they might be asked to leave the school or have to add an additional semester because they'd have to withdraw and they didn't have the financial resources to do that. Some thought their name would be splashed through the media because the university might share that publicly. And so then they become kind of this laughing stock of their community or even more broadly. But a lot of our mechanisms when it comes to data and trying to develop solutions for people involve problematic mechanisms that make it hard or scary to report. And I think that's the second thing we really need to focus on when it comes to coronavirus and surveillance. We need to make sure that it doesn't feel like policing and we're developing response mechanisms that are helping people in ways that are ethical and inclusive. It's no surprise to me that we're seeing the rise of coronavirus in our country and our response kind of coinciding with this response against police brutality. Because while one may be more in a physical space and one might be in more of a digital space, I think both are really concerning and at odds in our country right now. And they're both places where we need to really think through how we respond so that we're being more inclusive and more ethical. And it might mean kind of rewriting previous responses that our country has used.
But yeah, the parallels between what is happening around incidents that began with, for example, George Floyd's murder, and the fact that we're dealing with COVID. One line that someone sort of offhandedly said was, "It's like it's 1919, and 1968 all rolled into one." And then someone repeated, "And 1929" when you throw the economic collapse into it. But I agree with you. It's no surprise that these things are going hand in hand if you think about this in terms of policing, surveillance, and inequity. It makes very good sense to me. So one question that I'd like to get to is, because I think all four of you have very different perspectives to answer this, and I kind of will work my way through, and maybe I'll go back and start with Andrew again for this. We are seeing a continued growth in infections. As the infections pile up and as someone stays infectious long enough that growth, the R naught tends to be above or below 1 pretty much consistently in the country right now. But we've seen a significant decline in mortality, and we don't see pressure on our ICUs the way that we did in March, April, and May. It's not, from what Nigel tells me, because we've suddenly figured out how to treat these folks. We probably have done certain things better. We know that, for example, positioning may be better than a respirator, but by and large, we haven't had some big medical breakthrough that is preventing the mortality. Why are the infection rates continuing to be high, but the mortality has dropped so much, Andrew?
Yeah, I mean, I think that's a complicated question with a lot of sort of layered answers here. I think at one level, when this sort of sprung onto the scene, it caught a lot of the metropolitan areas off guard, right? You're talking Seattle, you're talking New York City. And so a lot of sort of precautions in the really high risk populations that we know today, like elderly populations, were sort of hit at a level higher than they are now, right? I'd say today we're doing a better job at trying to insulate nursing homes and elderly care facilities than we did very early on in the pandemic. And sort of early on, I'd say the infection rates were sort of driven by those metropolitan areas, whereas now we have sort of layers of, people stayed home for a while, and now they're sort of coming out into sort of society again. You've got college students coming back to class, and we sort of know that they are at lower risk themselves from sort of developing serious disease. That doesn't mean they won't develop serious disease or they won't develop consequences years down the road, because we just don't know the answers to that. But today the risk seems to be lower. And so as they populate with each other and interact, that sort of lower risk population may drive those infection rates and bring down sort of the mortality rate. And, we do have sort of better sort of ideas when you're starting to get severe. We can now use dexamethasone and some other things and sort of early treatment plans to try to help out and lower that mortality. Physicians are getting a little bit better at trying to sort of do standard of care with this sort of infection. But it's still a really good question that I'm sure the other folks on the panel also have excellent answers to.
Yeah, so let me turn to Nigel and ask about this from the point of view of the amount of exposure that a person receives. And there seems to be some evidence to suggest that if you have a relatively moderate exposure to the virus, that the case that you develop is less severe. And in fact, is it the case that you could have multiple very small exposures and remain asymptomatic or close to it and develop some form of immunity, Nigel? Oh, you're muted, so go back to your phone again if you would, Nigel.
Can you hear me now?
Yep.
Okay. Oddities of the phone. First of all, let me return to the point you first made, which was that the mortality rate is declining. We are still seeing 1,000 deaths a day in the United States. It's not exactly a decline. The peak in May was 2,000 deaths a day. We're down to about 1,000. We went through about 1,500 in July, with a larger burden of diagnosed cases. Now, two things have happened. One is an enlargement of the testing capacity, so a larger outreach into the community. And secondly, what we've also seen is a younger patient base, a younger group of people getting infected. So I wouldn't take an enormous amount of comfort from such decline as there has been in mortality. We're still in a very high epidemic situation with 1,000 deaths a day. I think in terms of, has there really been any change in the virus? I do agree with Andrew that in the early days, I used to hear some figures from New York City, the hospital I'm quite familiar with. I trained in really quite extraordinary figures on the number of patients that had to be cared for, the crowding, the absence of ICU facilities, ICUs on the regular floors. It was a mess, and things have gotten better in those crowded areas, and the epidemic has spread out a little bit more, so there's more opportunity for treatment. I think lessons have been learned about how to manage a little bit, but I doubt that anything substantial has changed in the virology at the moment, or maybe, and it's anything about the dosage, the amount is really speculative. I think we're still dealing with a very severe viral agent, and the proportion of the population that is getting immune, which has been suggested to be as high as, maybe as high as 20% in the greater New York area. I mean, remember, New York City, in the months of April, May, and June, lost 1 in 500 of its population to COVID. Some 30,000 people. Not one city. It's really, there is a background rise in the number, but it's nowhere near sufficient to produce any form of herd immunity.
Yeah.
So we've got people ahead of us.
So we haven't even gotten close to talking about vaccines yet, and as we sort of keep working our way into this, when we start thinking about immunity, the first question is about whether or not we can develop herd immunity to it, either by just continuing this grind that we have been on, and as Nigel says, even in the hardest hit areas, the maximum potential number of people who had contracted the novel coronavirus is 20% or less. The numbers that I'm hearing across the country, closer to 10%. My understanding is we won't actually see an impact from herd immunity until is it over 60%? We'll actually start seeing some reduction. So a very, very long ways to go to get there. The disproportionate impact of the disease or of the virus and then the corresponding disease for some communities leads me to ask this question. For people who have had more, I will say it this way, it's kind of upside down, they've had more opportunity to be exposed to the virus because of having less opportunity in life, as both Deborah and Nigel laid out. Do we have any confidence at all that those folks or those communities may develop more resilience and less morbidity and mortality because they got hit harder faster. That is, will we see different communities come out of this epidemic sooner than others simply because it hit some people harder faster? Deborah, what as an epidemiologist, what do you think about that?
Well, so that's an interesting question. So I want to just give people a way to think about the case rate and the death rate, right? So every number has a numerator and a denominator. So the numerator for cases is, for the case rate is how many cases we have over the population. Well, the population's staying pretty constant. And even though there are lots of deaths, it doesn't substantially change the denominator, the population. But that numerator, the number of cases, is influenced by a bunch of things like Nigel said, right? Testing. If we did nothing more than increase testing, we're going to see an increase in the case rate. And then on top of that, we've had cities that have reopened. So then we, and people are starting to re-engage. So then we increase exposure, right? So some of it is an artifact of those cases were already in the community. We weren't identifying them. With more testing, we're better able to identify case. It's important that people know you're only identified as a case based on a positive test result. There are lots of people who got coronavirus, got the virus, recovered at home. They're not counted anyway. Now a lot of those people are getting counted. And the increased testing means we pick up a lot of asymptomatic and milder kind of cases, okay? So we've done a lot, and there's a lot that's happening that increases the numerator, which will make the rate go up. That numerator is the denominator for the death rate, because the death rate is the number of deaths over the number of cases. So all of these factors, engagement, better testing, more testing, testing asymptomatic folks, all of that now makes the denominator for the death rate bigger, because the death rate is of the people who got it, and that number's growing, not somewhat in reality, some as an artifact, right? And then the number of deaths can even stay constant or go down a little bit. But the denominator getting bigger automatically makes the death rate go down. So it's important that people sort of understand that, because with all of this information and so much even bad information coming out, I just would hate to leave people with the thought that they're somehow at lower risk for either contracting the virus or that they're at lower risk for death. And we have had improvements in therapeutics and all of that, but that is not the primary driver for the decrease in the death rate. I just wanted to make sure that that was clear.
So what I'm hearing from both an epidemiological and from a treatment of individual patients, so a personal health and public health perspective, is that it's still April. That is, it's still the same virus. It's still impacting our communities to a degree very similar to what it was before. We may have shifted disease burden a little bit as we have tried to be more protective of certain groups of people, but by and large, it's still April. The metrics look different because we're really measuring different things than we were measuring before.
Yeah, and remember when we first started, we were testing mostly high exposure symptomatic cases. We've expanded that. Yeah. Right. And also back in April, things were kind of on lockdown. And so it was a much smaller group of people who were being exposed. We've got more exposure now, and we've got more cases that we're able to identify because of increases in testing.
Yeah. Yeah. Well, and in the big scheme of things, the 5 or 6 months that we have been exposed to this is a tiny amount of time from an epidemiological perspective. So it ought not surprise us that it's still very much like it was in April.
Yeah, so I didn't really answer your question. You asked about, and I'd be curious to hear what my epidemiologist physician colleague thinks about this. I just think it's a very dangerous notion. Someone said this about the opioid epidemic, because African Americans are significantly less likely to be prescribed opioids, even given legitimate and severe pain. somebody made the statement to me, well, you know, then they were less impacted by the opioid epidemic because they never even got a chance to get started. And sentiments like that are so hard for me to swallow, because if you've ever been around somebody in pain, in real pain, to not have access to our best advancements is just, it's not who we are as a nation. It's not who we say we are. And so the hard hit for it to actually, I think, provide some type of resilience, or a community or a subpopulation group be out in front on being protected or getting to herd immunity faster, there's going to be a lot of death, a lot of disability, a lot that's going to happen along the way. So, like, it's almost a tough question to answer, because sort of logically, is that possible? Yeah, it would come at a tremendous cost. And I don't think it's even in a universe from a public health framework, a strategy that we should be sort of considering or thinking of it through the lens of, well, there's some benefit here, because I think there's more harm and more cost than anything.
I see Craig Klugman ran the numbers for us on this. Herd immunity is calculated for COVID at approximately 58%. Running the numbers forward from where we're at, in order to obtain a 58% exposure rate, we would need about 2 million deaths in the United States.
Yeah.
So you're talking about between 4 and 5 times the number of Americans who died in World War II. I mean, that's an amazing number. And as he concludes, it's not an ethical approach to just wait it out in that regard.
And death is only one metric. I know many, many people who've had this virus, and some have done okay and recovered okay. I had a cousin who was down for 3 weeks. He said it was the worst thing he had ever been through. He had no history of asthma, no any of that. And he said not being able to breathe, and especially at night, he said it was one of the scariest things ever. He said if his wife wasn't there, he doesn't think he would have been able to make it. He would have gone stir crazy and out of his mind.
One of the benefits and burdens of my job is when the president made the pivot last week, I got a ton of email, either angry at me, but a significant number also being very appreciative, and many people saying, I had it. Let me tell you what it was like. And, you know, an 18-year-old student wrote me and said, I had it. My entire family ended up with it. I was down for 7 weeks. And this was not, you know, I was uncomfortable for 7 weeks. I was down for 7 weeks. We also know that there's a whole bunch of either lingering or related impacts that it has. Cardiomyopathy has emerged as one of the really big ones. That this virus seems to damage organs at a pretty alarming rate. So yeah, I think you're right. The mortality is not the only metric we need to be looking at. It's quite a bit more than that. Christine, I want to take a pause for a moment and ask you about a term that I heard used a couple of minutes ago, and it's a term that I know we can apply in different settings, and it has remarkably different impact as it's applied. And that was the concept of resilience. And I saw your eyes peek up when I can see all the rest of the audience can't, but I can see all the panelists. So you kind of peeked up on that. What is it about resilience?
Well, I wanted to talk about that word because I actually think it hits on what Deborah has been talking about here, and that resilience can really be a dangerous word. The majority of my work is with post-Maria Puerto Rican community groups who had to take care of themselves after Hurricane Maria because there was a failed response on the terms of the local government as well as our federal government. And those groups are frequently called resilient. That became a very popular term. But what they take it to mean, and what they've shared with me, is that it meant we were left to fend for ourselves and we were told that's fine. We didn't need help. We were resilient. And so I think there is a certain group or a way that this term can be slanted so that it does mean those people aren't deserving of or don't need our help. And I fear that if we're not careful with our use of the term, we would see, as Deborah mentioned, BIPOC individuals being told, oh, you don't need medicine, you don't need the best medicine has to offer, you're resilient, and that only exacerbates the disparities we're seeing right now.
Yeah, so very much this notion about why it is we see differential application of painkillers by race and gender, but then think about it as differential applications of healthcare treatment. Andrew, we text with each other behind the scenes on this. So Andrew just texted me something, and it makes no sense to me, but I'm dying to hear what it means. Andrew, you said raise the issue of long haulers. What is a long hauler?
Yeah, so I mean, Deborah sort of made this point, right? I think we seem to be very, rightfully so, concerned about the death rate and how many deaths are happening, but that really forces us to overlook folks that have these really weird sort of outcomes of this infection, right? So there's been a lot of really recent stories on middle-aged women with no pre-existing conditions that end up having COVID-like symptoms for months and months. They get headaches and migraines, they have back pain and muscle pain, and they go to the doctors, and the doctors think like they're making up their symptoms and never thought they had COVID over this long period of time. And, I think Ed Young, who's an Atlantic author, really sort of put it best at some level, where he says, when you have a really new infection and you have such high rates of infection, because the immune response is really complicated and it's hard to understand, you're gonna see some of these effects that you wouldn't have predicted based on your standard immunology model. And so I think it's important to know and sort of make clear, like, just because you're not dying from the infection doesn't mean you're not going to deal with the repercussions of that infection for weeks, months, and maybe even years that we don't know about today, right? We've only started dealing with this thing for 6 months, and how long-term those effects will be is totally unknown, and we still have no good way to deal with those symptoms because we don't really know what's causing them. We don't understand the underlying biology of how these long haulers are driving this infection. Do they have some sort of latent pool of the virus that we don't know? We really do not understand that level at this sort of point. And so I sort of want to just loop around and sort of reiterate Deborah's point that, like, death is not the only metric here that should be important. It's certainly very important, but there's other things I think that drive some of the symptoms here and drive sort of the personal and economic effects, right? If you're a long hauler, you can't go back to work. So how do you support your family, and those types of things becomes really sort of societal questions that we need to deal with.
So we're getting a good number of questions in the Q&A about how is it that we qualify death as caused by coronavirus. So how do we distinguish between people who have died and have coronavirus and people who die and coronavirus is a causal factor in their death, either directly or through comorbidity? So as we're looking, and maybe this is a question for the epidemiologist, I think I've talked myself into that. Start with Nigel. Nigel, how are these determinations made? Is this I would say simple science? Are these clearly objective measures that we use?
The death certificate process, the process of filling out a death certificate, is a very important part of actually the legal matter. I mean, a death certificate is a legal document. We don't like anybody to die without a death certificate. That raises all sorts of unfortunate questions. And almost everybody who dies gets a death certificate, Jimmy Hoffa notwithstanding, And on that death certificate, people are supposed to write the immediate cause of death, the underlying cause of death, and contributory cause of death. And the attendant, the doctor, or the health professional who took care of the patient is supposed to write that down. Now, what if somebody's found in their house dead? Well, now you've got a problem. That in most places you have the coroner, the official medical examiner, has to examine the body and establish a cause of death. You want to be certain that the person wasn't done away by some nefarious act, right? So that process goes on all the time. The underlying cause of death is the most important one, the one that's most tabulated. One would presume that in most instances, someone who dies would die in a hospital, would die after some period of care, would have been known to have coronavirus, either by culture or by clinical matters, and you would write that down. In New York City, they made a very special attempt in the New York City Health Department to look for people who might have died of COVID who were not so classified. And they actually added on the order, and this gets to what Christina was saying earlier, on the order of, I would say, something like 10 to 12% more people. A lot of these people, there was a period of time in the bad days of April and May, the New York City was counting 8 deaths at home thought to be from COVID. People had not sought medical attention. Elderly people living alone, they'd caught it on the bus, they'd caught it on the subway, they'd caught it on the street, and they died at home. And those were all medical examiner cases. And they made some extrapolations, and from that, and the figure, they enlarged the figure of the number of deaths. And I think Christine is quite right to say the 180,000 we've seen is probably 80 to 90% of the correct figure. And there's a residue of other people. And you know, sometimes it can be difficult. I can see that. You know, a stroke occurs. Could the person have really had some COVID before that stroke that we didn't really know about? There are going to be some ambiguous cases. But I would just say cause of death is fairly well thought about, at least in the United States right now. And death certificate processes are important ones to take account of, and they're usually well done.
The long hauler question that Andrew raised for me is getting a lot of follow-ups, so I don't want to walk away from it too quickly because I think others have a lot of questions about it. So let's deal with it narrowly from the point of view of what do we think the mechanism for that is? Why is it that it seems to sort of hang with folks? And then I think I'll bounce, if I can, between Andrew for the first question and then Deborah and Nigel for the second. Do we see a distribution of long hauler cases that suggests something about it? That is it more frequent in some segment of the population versus another that might give us some information about what it means? So Andrew, what do you think the mechanism is that explains this long hauler effect?
You know, it's a really good question, right? And I think it's really intriguing to a lot of immunologists that try to understand inflammatory diseases and responses to infection. I think an interesting thing with COVID is, unlike, you know, we consider it a respiratory disease, but it also seems to escape from the lungs and start infecting your endothelial cells. There's maybe some evidence it can start causing inflammation in the brain and those types of things. And so the problem is all of our diagnostics are, you know, nose swabs and those types of things looking for nucleotides that are associated with the virus, right? But if it's now gone somewhere else in your body, you're not going to be able to sort of sample that environment, right? And so, you know, I think one, we don't totally know where the virus is going in anybody's body at any particular time. That's a really, really challenging question. Even if you're doing, like, you know, controlled animal models, like we do tuberculosis stuff, and it can disseminate to other tissues, you don't know where it is a lot of the time. And two, we don't know the effects of if it's infecting endothelial cells or in your heart and those types of things. Is it the inflammation that's driving that? Is it then the cells and sort of the host response that's responding to that, that's then causing damage in those tissues? There's really sort of a tug of war. You know, with TB, we always say there's sort of just this like perfect amount of inflammation you need, and you have too little, the pathogen can go crazy. You have too much, and now you're actually damaging yourself. And when your virus is in other places where you don't know, we think that could really be, you know, driving this, right? But, you know, I think the inflammation, you know, I think I saw somebody asking about NSAIDs and those types of things. You know, it really could be that dampening down some of the inflammatory effects could have a role, right? With severe COVID patients, that's why we use steroids and dexamethasone. It's really dampening down that inflammation that can allow your lungs then to function. And it might be that there's other sorts of reservoirs of this virus in patients that we don't understand that could be persistently driving this inflammation and having these oscillating things, right? With, you know, I did my PhD in chlamydia, and one of the big things with chlamydia is you have these oscillating infections where you have patients that have symptoms, don't have symptoms, have symptoms, don't have symptoms. And it's because these pathogens can adapt to sort of those inflammatory environments and tone down what they're doing until the immune response thinks you're gone, and then you can start replicating again, right? And whether that happens with COVID, we just don't know, but it has a lot of signatures, a lot of these sort of persistent pathogens that are still sort of wreaking havoc in the world, like TB and those types of illnesses.
So from an epidemiological point of view, Deborah, do you see it's striking the long hauler effect, striking some communities more than others? Or Nigel, I'll follow up with you as well.
Honestly, I don't feel qualified to answer that. And it really is emerging, right? Like for us to really understand this, we're gonna have to, this is just like such a crazy way to think about it, but we have to almost wait and see.
Yeah.
Right? And as we get cases and as those cases come forward, I do know somebody who is a long hauler and didn't realize that that's what they were dealing with. It's the only thing that changed. They never got a test. They had what they now can recount as some milder symptoms, and they just never went away. And they went and got an antibody test. They got an active test, no virus. They got an antibody test, they have COVID antibodies and have been dealing with this for about 4 months. So I think we're learning, and as we learn and get the data, we'll be able to better understand who's at, epidemiologically. I mean, you guys have the great theories as it relates to assertive medicine and pathology, but epidemiologically, we're learning.
Nigel, you're facing both directions for us on this, both the patient and the public. Do you have some sense of an explanation of this long hauler effect?
Context Andrew has given is very important. Infectious diseases, many infectious agents have figured out clever ways. Oh, you can't hear me? Can you hear me?
Now we can hear you well. Go ahead.
I had to mute and unmute myself. Go figure.
No, I think you need to keep the phone closer to you.
Oh, I see. I'm so sorry. Okay, that was my mistake. The infectious agents have developed a variety of ways of hanging around, and Andrew has talked about them. TB makes itself into a little gland complex in the upper part of the lung and sits there for 40 years and decides to wake up when you're 60. Chicken pox sits in a nerve and then reappears as zoster in your old age. And with so many mechanisms, clever mechanisms, the infectious agents have for evading immunological surveillance, and either giving you recurrent infection, chlamydia is an example, or just sitting asymptomatic, or you can become an asymptomatic carrier, a typhoid carrier. There's so many examples. And we don't really know what the situation is yet with coronavirus, with SARS-CoV-2. I think the studies should be now begin to be assembled. We got to get people who recover and follow them carefully. Follow them for symptoms, follow them for immunologic patterns as well, and try to understand what's going on. I have seen as yet, no signal is sufficient to say we know that it varies from one community to another. I think it's as Deborah said, we're still just at the threshold of learning about this. But in fact, this is the time in which epidemiologists ought to be assembling cohorts of people who have recovered from COVID-19 and following them systematically to learn what kinds of complications ensue and what kinds of baseline risk factors predict those complications.
So reinfection is, I have a list here of broad topics we may want to touch, and reinfection is most certainly on that list. We have, I think earlier this week, maybe last week, a report from Hong Kong of a definitive case of reinfection. My colleague and friend over in Lyman Briggs in philosophy, Sean Vaez, wrote a really thoughtful Facebook post about that and said, the good news is we found somebody who was reinfected, which seemed like a crazy thing to say until he unpacked it for you. He said, we had to look really long and hard to find somebody who we can confirm was reinfected. This is probably really, really rare. We are seeing a few other cases that seem to suggest that. Do we have some degree of confidence that having been exposed to, having contracted the novel coronavirus confers some lasting protection against it? What evidence is there out there that suggests that for us? I'm going to kind of wait for a hand to go up and let you answer.
I mean, I can start to go at this one, right? This is, again, I think is a really challenging term, because one thing that's important to note is that when we say you're immune to something, that doesn't mean you're not going to get infected by it for some amount of time, right? There's a difference between having immunity and having sterilizing immunity, which means you never actually have an infection, right? We have to get the flu vaccine every year, which gives us some level of immunity, but some people will still get the flu even though they had the influenza vaccine, but they might have dampened symptoms. And so one, I think the case out of Hong Kong is, you know, one, it's good that it took a while to find somebody that was reinfected. Two, their second case was much less severe, which suggests that their memory response might have been working effectively. You know, I think there is one report coming out that somebody did get reinfected and had worse symptoms, but you know, that data seems to be really low, and it seems to be sort of not super common right now, which I think is at least compelling in this short time window, which is 6 months, that, you know, there is some amount of protection that might protect you against severe disease in a second exposure. But that doesn't mean just because you've had it, you're not going to get some productive viral infection for some amount of time while your immune response now has to reactivate and kill that, right? And I think that's an important thing to note, is that just because you've had it doesn't mean you can't get some sort of subclinical infection and spread that to somebody else. We just don't know the data on that. And I think that's really key, that, you know, I know we're eventually going to get there, like, what does immunity mean? And do we have immunity passports? And I think that becomes a really complicated topic to really sort of understand without good evidence.
I could weigh in a little bit. You know, the trials are going to show us. There's several trials. There are trials of convalescent plasma ongoing. They would give some indication of whether the presence of antibodies protects you. Then there'll be the trials perhaps of hyperimmunoglobulin products in an attempt to prevent the disease. And then eventually there'll be the vaccine trials. Now, all of those will tell us something about immunity and how persistent and how lifelong, and how whether infection, natural infection, causes immunity. It's very hard at this early stage of the game to really make assertions about this firmly. There are some animal experiments that have been done in which animals have been protected by the presence of antibody that has been transfused into them. And we think the human data is a little bit sympathetic to that too. So, you know, there are some small signals that antibody response is protective, but for how long, how robust, you know, is it going to be like smallpox, you know, or measles? You get infected and you will never be infected in a lifetime. 60 years later, you'll still be protected, you know, or it's going to be something a lot weaker than that. Who knows? We don't know yet.
So the list of things that I know I need to get through in the 2 hours includes the questions about testing. Really, as the testing rates change, and you know, we had imagined a continued climbing number of tests, but in reality, we're actually seeing some interesting oscillations in places and times, and different people being tested, going from symptomatic, entirely symptomatic people to now asymptomatic people, and then different testing methodologies, going from, say, nasal swab, something that is recognized as the sort of gold standard, to now the saliva tests, which, if I had my choice between the two, you know which one I'm taking. One is far more pleasant than the others. But as we start thinking about testing and testing rates and who we're testing and why, the question that emerges for me is, as we focus testing on different groups of people, how is that going to change both our understanding of the virus and accompanying illness, and our perceptions about it? So Deborah raised a little bit in discussing the numerator-denominator problem. It really looks like morbidity and mortality is falling. In reality, it's still April. But the other issue that, of course, that comes up is, if we're focusing testing on certain groups of people, why are we focusing on certain groups? And so there are real concerns that when you have the lens turned on you, that there are negative consequences for it. And I will tell you, part of the calculation in not opening a college campus is because we suspected that students would not want to be tested because, as one of my colleagues said, if they come up positive, they know they get thrown in the hole for 2 weeks. So can we talk about testing for a few moments, and the sort of the problems that are created by the fact that this is not either evenly applied, nor is it entirely welcome for some groups of people. So I drive by the Sparrow drive-through at the old Sears, and there are long lines there. But I also know there's large numbers of people who absolutely don't want to be tested. Christina, could you unpack that a little bit for us?
Sure. I think there's a number of factors that play into this desire of wanting to be tested or not tested. And I hit on a few of them. So some people have privacy concerns, or they have fear or shaming concerns. And others have more of a liberties kind of stance, that they feel like it's their right to choose whether or not they receive testing. And I saw the question in the Q&A that talks particularly about churches. And I think that there are certain narratives within different communities across the United States that can make testing kind of a touchy topic. And as someone who was raised in an evangelical household, I can say they're members of my own family as well, where people are taking the coronavirus less seriously, or they don't see it as a real threat. They feel like if they were to be tested, in some communities that I grew up in, that I was familiar with, if you're ill, that means God is mad at you, right? We have all sorts of narratives that play into these choices for people. And I think from a surveillance ethics perspective, what we would say is we want the greatest number of people to have access to testing and to feel comfortable with the testing. So we want to break down those barriers as much as possible. We want to make sure we're not using testing as a form of policing, we're not using it as a form of shaming, and then we invite people to opt in to the best of our abilities. But I think we always have to be aware, particularly in a country like ours, where there really is kind of individual free choice in a lot of ways. There's not a lot of cultural mandates around our behaviors, that there's always going to be a group of people who choose not to opt in. And we need to kind of formulate our data sets around that, be aware that those gaps will always exist.
So the idea of being tested and being found first positive, but then recovered from it, puts a person in an interesting category. And I think at root, the question that had animated this Brews and Views was one about people having immunity passports. But of course, in order to have that, you would have to first have the diagnosis of being positive, which may have accompanying shame or accompanying, as a term that I'd use, thrown in the hole. You're self-quarantined or perhaps quarantined from an external entity. In order to get through that, to be now cleared of the virus and have some degree of immunity, hopefully for yourself. But then the notion about where it is that something that Nigel had brought up earlier would come from, and that's plasma donated from people who had tested positive, now test negative, and are donating plasma that can be used as convalescent plasma. Nigel, you suggested a relatively high degree of optimism that this was a safe treatment. There was evidence of its efficacy. I know we're going to lose you at 6:30 when you have another commitment. So I want to make sure we spend a little bit of time on this. The plasma donation and then its use in therapy on folks, you said is safe because we have a long history of its use. You called it, I think, an ancient therapy, one of our earliest. Unpack it a little bit for us, will you, so we understand what we're talking about, and then why it is that you see this as potentially a viable alternative.
Well, let's take safety first. Every year, approximately 2 million plasma transfusions are given in the U.S. That's fresh frozen plasma. It's generic plasma. The difference between that and COVID and convalescent plasma is we presume that in addition to everything else that's in plasma, the person recovering from COVID-19 has antibodies that may be helpful to the next person. So historically, convalescent plasma has had a good record of safety. The Mayo group, I have to give a little history. The first step the FDA took was to allow people one at a time to get this new experimental biological product, convalescent plasma, from people with COVID-19. You had to fill out a 4-page piece of questionnaire for every single patient. That lasted from late March to early April, about 2 weeks, still available. And then they announced the Expanded Access Program. And what it was a study. They initiated a study, and Mayo Clinic became the repository of what was in effect a registry of virtually everyone in the country who had been treated with convalescent plasma. And you had to get informed consent, just like in any other study, but it was a one-arm study. There were no controls. And safety was the principal objective, and 2 papers were published, one after the first 5,000 patients were on the registry, the next after 20,000. Those are both available. Actually, the one with 20,000, which came out later, is published sooner, such as Life, in journals, and it's in the Mayo Clinic proceedings. And we see really good signals of safety. Very, very few of the side effects that people worry about: TACO, transfusion-associated cardiac overload, TRALI, transfusion-related acute lung injury. Any of the other enhancements of cytokines that we worried about are present in minuscule frequencies, and these had to be reported on by every person who registered a patient in the registry, which now, by the way, is over 70,000 people listed on that, in that single location. That has come to an end now because of the FDA action that was made Sunday, which had changed from the to the expanded access, which emergency access, excuse me. And that means it's an emergency declaration, a product that has evidence of safety, some evidence of efficacy, not quite the full story because it's emergency, for use in special circumstances and inpatient basis only. So that's where we are now. The evidence of efficacy comes from a number of places, a number of comparative studies between people treated and untreated, 2 randomized trials that were too small to show statistically significant reductions, but did actually show reductions in death rates. And perhaps the thing that pushed the FDA over the edge to make a decision, which was that we went back and I should say I'm involved with this whole Mayo Clinic effort, which is linked to Michigan State and many other institutions across the country. We went back and we looked at the retained little small portion of serum or plasma from every plasma unit that the blood bank retains. They retain a little bit in order to test it in case someone should come down with a complication or infection to see whether the unit was contaminated. So we were able to locate 3,000 to 4,000 of those, they sometimes call them dog tags, the little leftover bits of serum, and tested them for antibodies. And now when the person got plasma, nobody knew what the antibody level was, right? Completely. And it turns out there's a dose-response relationship in mortality to the level of antibody it was in the plasma that was given. The higher the antibody, the lower the mortality. Now, this to me is something like a randomized trial. Nobody had any idea in advance what the level of antibody was in any given plasma unit. And it's a little hard to imagine something that could confound or bias that finding. At any rate, we argued in the paper that is also on the medRxiv server, not yet published, it's being considered by JAMA at this moment, that this is a strong signal of efficacy. And the FDA, who went back and forth on this with the Mayo people daily for weeks, looking at data, more analyses, more subsidiary analysis, this antibody, that antibody, 3 different forms of antibody were used, finally convinced themselves that it really was ripe for a broader use, an emergency use, and that's what the FDA announced on Sunday. The news conference that took place, the political psychodrama that took place, in my mind, were all completely irrelevant to the decision, frankly. It was made by the Division of Biologics, by scientists there in that subsidiary unit of the FDA. We watched them do it. We watched them ask for data. We watched them look at data. We watched them converse with us about the data. And we think they made a decision that was based on the data. We can talk about, trialism and the need for an absolute randomized trial with sufficient power to make a decision, and that's an interesting issue in the philosophy of medicine. But I think they made the right call, as Arturo Casadevall of Hopkins and I wrote in Bloomberg News Today. We wrote an op-ed arguing that this was the right call. So that's our opinion. Others can feel differently. I think they did the right thing, and I think they did it free of significant political influence.
It's to put it lightly, inconvenient when political influence coincides with a process that has integrity, because it immediately clouds the
Absolutely. Totally clouded the picture and made everyone rightly suspicious. I get it. I completely understand it. But I think we were in the kitchen watching the meal being cooked.
Yeah. Well, so let me ask a practical question that demonstrates my ignorance about this. So if you donate plasma, I know from seeing the roadside signs that there's that you're compensated for your time in donating the plasma. If you have
No.
Sorry.
There are two universes, two parallel universes. There's the blood donation world, the blood banking world, and there is the plasma fractionating world. These are two different universes. The blood bank world is based on voluntary donations. The Red Cross, other groups, the New York Blood Center, Vitalant, they don't get paid. People don't get it. They give blood. It's the gift relationship, as Richard Titmuss, the great sociologist, wrote in a book, very famous book in the 1950s. It's the gift. We give, gift of blood. The convalescent plasma group, the people who've recovered, call it the fight within us. That's their organization to encourage plasma donations. Plasma that goes to plasma centers is for fractionation. It's for the derivation of components of plasma, and that is a commercial activity. These are industries. They are now working on developing an immune globulin product. My understanding is they're working together and trying to create a generic, low-cost product. I hope that's the case. But they cannot give, their plasma they take cannot be given directly to people. There has to go through a manufacturing process. Only the blood bank world can give plasma for people to use. And there's Red Cross and Vitalant and the New York Blood Center occupy about 60 to 70% of the blood bank world. There are other places, other organizations that do this, but none of them pay anyone. This is a complicated business.
So plasma donation has no compensation for the donor.
Correct.
Okay. So for a person who donates it after they have cleared the virus, there's no difference in compensation because there's no compensation to begin with.
That's right. Now they could go to a plasma fractionator with their plasma. They could donate there so that it could be used, and that's not a bad use to create various products like an immune globulin for plasma. We were very worried at the initial stages that the companies who pay would be able to suck up the donation pool, right, away from the blood bankers who don't pay. We put them actually on notice about this. We're watching them. It didn't happen so much. But however, there are parts of the country where there are no blood banks and only plasma fractionators. So if you wanted to give, you'd have to give to a plasma, unless you wanted to travel, you know? So there are complexities. The blood bank world and the plasma fractionation world are really interesting and complicated institutions, I have to tell you.
Well, that's a helpful background, and I really appreciate it. And so as we're thinking about the differential opportunities to participate in this process, to donate after you've cleared the virus, and at the same point, we've already discussed notions about shame or why someone might be hesitant to even be tested, much less make a public admission that they had contracted COVID. We end up in this interesting with this interesting tension between the two. So it's almost as if contracting and having the virus is problematic, but having had the virus and be cleared of it confers on you a certain elevated social or biological stance relative to somebody who never contracted to begin with. So it's an interesting sort of contradictory position for us. But where it becomes a question for me is, do we have some way in which a person would be able to document that immunity? That is there a reason why someone who has had and cleared the virus, it would be useful for us to be able to distinguish between um, uh, somebody who may have natural immunity to it and somebody who may not? And that is, after all, the root question for this the 2-hour period is, you're immune to COVID-19, prove it. And so are there mechanisms for us to be able to state our immunity if we have, I'll say, earned it in one form or fashion? Titer tests, for example, are used to avoid vaccine requirements for K-12 participation. Would there be something equivalent to that for COVID-19? Yeah, I see a lot of head tips and eyebrows on it.
I mean, I think as sort of somebody that works on vaccines, I'd say the biggest problem we have right now with COVID is we don't know what immune responses actually provide protection, right? And in biology, what we call it is correlates of protection. So what immune responses, cell types, antibody types, other immune type of responses actually give you protection. And I think the problem with some of the antibody stuff is you assume that just because you have antibodies against COVID, that those antibodies are protective. And at the end of the day, we still do not have clinical trial evidence or sort of an understanding of what actually is a correlate of protection, right? It very well may be that antibodies provide some amount of protection, but if you don't have antibodies and something else, you still could get severe COVID. We don't have that evidence. And I think that would be me sort of pumping the brakes on saying, just because you have positive antibodies, you now should be allowed to act like you are immune to this, because we still fundamentally do not understand what's providing protection. And I think it's all sort of on ourselves to realize, we don't know that. And so we should act like we've never had the disease until we know what's actually giving protection.
Yeah.
And I want to build on what Andrew was noting there, because I think even if we do get to that point, we want to be really careful with how we're asking people to document or carry papers or prove that they are immune or somehow in a different class of people. We know that there are long histories of how people have been asked to produce documentation about their rights to other things. There's a great book called Dark Matters on the Surveillance of Blackness by Simone Brown, and she talks about enslaved peoples being asked to produce passes to demonstrate that they had the right to move between different households. We know that people on the US-Mexico border have been asked to produce, quote, documentation or papers of proving citizenship, even though we never quite settled as a country what that is or what that looks like. We know that indigenous peoples in the United States also have had questions surrounding their citizenship, particularly prior to the Indian Citizenship Act of 1924. So I think as we're thinking through these solutions of what that might look like in the future as well, we need to be really careful that we're not asking people to participate in activities that they consider harmful or re-traumatizing, or that awaken these things of past memories that only engender more fear and more distrust for public health. Because after all, we want as many people as possible to participate in this public health initiative so that our country can move forward.
Yeah, the notion about wanting people to want to participate is, I think, really interesting to me. And Deborah, I want to turn to you on this question. We, in preparation for tonight, had a series of conversations, and to be honest with you, I really deeply enjoyed those. The opportunity to get to spend an hour thinking about this in an exploratory way with really smart people, I appreciated that opportunity, and thank you for inviting me into it. But we spent a great deal of time talking about vaccines, and we haven't spent any time tonight talking about the vaccines. So maybe this is a good entry into it. And Christina's notion about, well, we want people to want to participate in this because widespread participation is what we need in order to overcome the pandemic. Widespread participation in public health prophylactic measures, widespread participation in testing, widespread participation in vaccine trials. And I know full well, Deborah, from some of the things that you discussed before, that you understand very, very well the ways in which widespread participation is predicated on a degree of trust that we just have not earned among all people. Can you unpack that a little bit for us? Oh, we got to unmute you first.
Sorry. I'm always doing my most brilliant work on mute, always. And I've been really enjoying, and I realize I'm trying to answer questions in the Q&A and stay in the conversation, and multitasking was a lot easier when I was younger. But there's a few issues here, Mark, and we talked about it with testing, and I think it's all of our natural sort of instinct to start to look at the individuals and the people, right? So even if we think about testing, when, and I'm just saying this because somebody asked here, and I promise I wrote your question down, I will answer it explicitly, to talk about observations of testing in Flint. And so there was a point when the demand for testing, people who wanted to be tested, far outweighed the availability of testing. And then as we increase the availability of testing, and we've got a few things. We've got community testing sites. One is at a urgent care center attached to Hurley Medical Center. The National Guard has been here on multiple occasions, et cetera. The first time the National Guard came here, it was a zoo. Like, there was only one way in, one way out. People were in line the entire time. Some people were in line for 4 or 5 hours. People are getting out and covering somebody behind the building so they can pee. I mean, it was a disaster, right? But this testing didn't require that you have a script. If you didn't have insurance, it was free to you. But it did require that you have an ID, which just alienated, almost all testing requires an ID, which alienates a whole lot of people. It's probably hard to wrap your mind around for the people on this webinar that you would not have an identification. But so many people do not have a valid state-issued identification. And so what did they do? They told their friends and their family, oh, it's all bogus. We waited forever. They wouldn't test my so-and-so because he didn't have an ID. And so there's all these also structural factors that we don't think about. And in this sort of era of all of this information, the one thing that people are doing is they're sharing within their networks, with their friends, with their family, with the people they go to church with, and all of that. And I think we were learning to, like, I don't even like the analogy of learning to fly the plane in flight. What it feels like to me is we were trying to change the wheel while the car is still moving, right? Because we had to do stuff and put stuff in place, and then that stuff wasn't working. But the car is still moving, right? And then we started reopening, and so we were trying to change the wheel while the car is still moving. So we've greatly streamlined that testing that we do in Flint. But there's just this legacy remnant that people think, oh, it's a mess. It's where they want the poor people to go, right? That's why it's run so poorly. And really what it was is we were trying to innovate. We were, just trying to overcome the barriers of people who didn't have a PCP or, and then there were people who were doing transportation and some of these other things. So I do think there's some other structural factors that we need to think about when we think about both of these. As far as the vaccine and trust, it's an interesting thing because I've had 2 really cool webinars this week. One on Monday with Dr. Collins, who's the head of the NIH, and I had one that I moderated this morning with Dr. Robert Redfield, who is the director of the CDC. And Dr. Collins was just brilliant. He really broke down what's happening and all of that. And then he said, so you African-American leaders, how can we get African Americans to participate in the trials, because if they don't participate, we won't learn and we won't know. And I listened, and I'm writing notes as he's talking about all the funding that they've given out. And I'm literally looking people up on Reporter and online. And it's all old white men who are at the helm, and mostly, and maybe some young white men, maybe Andrew too. But it's all, you know, and I thought, well, this is really interesting. So the table has been set. The money has been given out. There are many, many, many underrepresented minority clinical trials, vaccine trials, preclinical researchers, et cetera. But when I looked at who was the leadership and who's running them, it's very male, and it's very white, and it's very old. And so I thought, here you are, the table's been set, the money's been given out, that's the feast. You've had the feast. And now we're coming in, looking at the sort of scraps on the table, trying to figure out how to get other people to buy into the work that came out of it. So I thought, we got to deal with this at multiple levels, right? There is the, to me, well-earned, well-deserved mistrust of many communities, including the African-American community, of the medical healthcare and public health system, because we have intentionally done things wrong. You know, there's a history there, that makes sense. But that doesn't account for all of it, because trust can be restored over time and through action, right? But then when I look, it's like, it would have more credibility. And I don't do vaccine trials, but if people saw themselves reflected in all levels, I think that would go miles. That would be an action that could be replicated over time, that would give these marginalized and previously victimized communities more confidence and faith in, we can trust the NIH, we can trust the healthcare system. But that's not what happens. What happens is the table gets set, there's a feast, and then we get called in after the fact to try to do trust or get people to trust. And so there's many pieces to it, but I think that's a really big and important one. It's going to be the actions consistently taken over time, and it needs to be at all levels. We can't just be recruiting people in the community, which is where you find most people of color on research projects. They're the foot soldiers going out into community to recruit people to sign on. But what's a bachelor's level person or able to say as far as the science behind it? People have real valid questions. So I think we got to deal with ourselves in equity at all levels.
It's
and
interesting
I just sort
the
of
way
like
in
to
which.
add, can I just add one thing there? Because, you know, she sort of got there, but I was digging into even the preliminary reports on the vaccines, the phase 1, phase 2 trials that are published, right? And you look at the representation of race among these trials, right? I've got the Moderna phase 1 trial up, 45 individuals, 2 African Americans, and 1 Hispanic patient, right? And so is that representative of our population? And immunology is complicated. It's important to consider genetic factors and how different populations respond to these types of things. And so I think, you know, all of these things are sort of coming to a head, and who's sort of the mouthpiece of why should we get these vaccines? What are these vaccines in the first place, which I'm sure we could get to. 2, who have these vaccines been tested on, and is that going to be different for different populations? And, you know, I stand right behind Deborah when I say, like, you know, I opened up this study today and was looking at it in preparation for this and was just kind of shocked and honestly, sadly, not too surprised that that's how this falls out. And I think that that's an important consideration when we consider what communities are recalcitrant to sort of get these vaccines and why they have significant justification to have that sort of hesitancy.
Yeah, I think, and Andrew, you can correct me. I think it was the Pfizer trial, because Pfizer has one too, and NIH has a big hand in that and has put a lot of money to it. Dr. Collins said it normally takes about 1.5 years to get through a phase 1 trial. And they did it this time. So that's about 550 days. And they did it this time in 53 days. So clearly we know how to innovate. We know how to move with velocity. We know how to get things done. there is no urgency when it comes to equity. And Dr. Collins was really great about it. He said, you know, if you look at all the money that NIH has set aside for anything minority related, minority serving institutions, it's only training programs. It's only training programs that have set asides for minority serving institutions. There is no, and I looked, there is no research mechanism that I could find earmarked or designated for minority serving institutions. I also could not find any funding opportunity announcements that required minority representation on the PI team. Because many of these, and they've given out, I don't even know the number. I stopped counting once I got past $1 billion, but there's no requirement that you even have diversity of gender, race, or anything on the team. So the big guys, the old guys, you know, the guys who are more known in these agencies and institutes, mostly because of historical reasons that are rooted in unfairness, are the ones who got to the table first or got to the table with the biggest, best, you know, sort of thing. And so, yeah, we know how to innovate. It's time for us to innovate when it comes, and to innovate quickly when it comes to equity. Dr. Collins said, you know, we've had a lot of the initiatives we've tried, and they had a report that just came out. It comes out every couple of years. They've made almost no progress. Even the Minority Institute for Minority Health and Health Disparities, they get more applications from underrepresented minorities, and the hit rate for minority PIs, given a score and everything else equal, is lower in the Minority Health and Health Disparities Institute even than some of the other institutes. Because majority investigators have figured out that there's good bread and butter over here too. So I just think we need to innovate quickly with velocity. If we can go from 550 days to 53 days for a phase 1 clinical trial, surely in the next year we can do something to increase pipeline and get more representation. Race, gender, rural, economically disadvantaged. I'm not just talking about diversity with race, although I think that's important. It's just not, there's no urgency around it. And I don't think it's a legit value and priority.
Yeah, there's no urgency around equity. I think that's I really like that phrasing, and I think it sums it up nicely. It brings us back closer to where we were at the very beginning when Christina had raised the parallels between the racial policing and justice unrest that we're seeing. I mean, when you start seeing it in places like Wisconsin, I mean, that's striking. And it happening at the same time as the COVID pandemic. So, Christine, let me ask you a question. You and I both agree to it, but I kind of want to unpack it a little bit. Why are these things coincident, or are they not merely coincident? How are they tangled together?
Well, I think this actually really well builds on what Deborah was saying, which is that our approaches for addressing disparities across these issues are the same. There are some different strategies the humanities recommends, and those are things like restorative justice or transformative justice, which basically is when groups come together, and groups that have been responsible for harm or crime against another community takes responsibility for that. And so that would be a recognition of our country's past behavior towards people of color, Indigenous, African Americans, Latinx communities. We'd want to acknowledge the ways in which these disparities have existed through legal systems, through incarceration, through citizenship questions, through redlining, through all of these different mechanisms that have disempowered certain groups. And we know that other countries have done this. The popular example is to hold up Germany. Germany talks about particularly its history in World War II and how it's very important that they acknowledge that history, and they're really open about the mistakes that they made so that they can move forward. And I think when you do that and you are willing to acknowledge those histories, that also opens up a space to say, oh yes, we really do need different forms of leadership. We really do need to invest in communities. As Deborah was talking about, I know that when we look at things like the Senate, it doesn't, or the House, like our federal House, it doesn't represent the population, right? And we need it to, because as much as I care about these issues and as much as I work on them, I'm a white woman. I will never fully understand the experiences of other people in this country and what they're going through. And I certainly try to work to make a difference and to create space for them to become leaders. In my own project in Puerto Rico, I follow the instructions of my community organizers. I just say, hey, I'm really good with technology. You tell me what to do. That's how we're gonna make this work. But I can never know those experiences. And if we can't hear those on a public level, in a leadership level, in our communities, then we can't move forward.
Yeah. There's something about communicable diseases too that create a special set of problems for us because we can't ignore disease outbreaks in marginalized communities because of their capacity to spread to majoritized communities. And it always seems like communicable diseases for hundreds of years now have really been the source of a great number of focal points around inequity, around power, around trust, around all these different kinds of things. All right, well, the sun is setting. As you can tell, I'm dodging the direct sunlight as I've been moving my computer around for the last 10 minutes, which means we're getting awfully close to the 7 o'clock mark. And I know we've approached this in an interesting way, taking people from very different vantage points, that we are a bit like the proverbial blind men and the elephant. We've sort of each got a hold of part of this. And the glory of an approach like this is that we can open it up for discussion. The bad part about it is that we never seem to really be able to drive deeply enough into any one of what the blind man is holding. So so let me sort of start and go the order that we did originally, and ask you guys to close by talking about the things that we haven't talked about, issues that you think are relevant and important to what we're working on, or issues that you think we raised but we really weren't able to drive more deeply into. And I'll do it the same way we started before. Actually, let's go backwards this time. I went Christina, Deborah, Andrew. Let me start with you, Andrew. We'll go reverse alphabetical.
Oh, I was just preparing. I thought I had some time there.
You leaned back like you
ready. I was ready to
confident
wait.
You knew what you were going to say.
All right. So this is what I would say is, as a biologist and immunologist, I'd say fundamentally we still don't understand a lot about COVID. And so the coming next 12 months, 24 months, years is going to take us to really understand the repercussions of this infection and what it has. I think in the coming months, we're going to have to sort of come to head with what the vaccines are and who's going to trust those vaccines. We didn't even touch on what these vaccines are, but all of the frontline vaccines have never actually, their platforms have never been approved for vaccines in humans before. And so what sort of issues does that raise? Particularly if you have the application of these vaccines before we have phase 3 efficacy trials and what sort of ethical problems that raises. As somebody that works on TB, one of the last points of how infectious disease drives social disparity, right? I'd say probably 90% of the people on this call didn't realize that tuberculosis is still the #1 killer by infectious disease in the world, killing 1.7 million people a year because it doesn't impact us in the United States. We just don't care about it, right? And now that COVID is in our backyard, we care about it. We care about how these infectious disease impact our families and our society. And I just sort of have a broader sort of mouthpiece here to say, we really need to care about infectious disease, how this impacts people, how these infections work, and put money into those types of studies, and understand how we can sort of educate the communities on how to reduce the transmission and impacts of those types of diseases sort of worldwide. TB isn't such an issue here, COVID's an issue here now, but we have sort of underlying conditions in the United States, sexually transmitted diseases and all these things that also boil up to the surface that I think we really need to consider and think about as a United States nation, and really what we care about in terms of protecting our families, our communities, and what our responsibility is to our neighbors, right? And I think that's sort of a big thing with this COVID is, why am I going to wear a mask? Why am I going to get a vaccine? Why am I going to do all these things when I feel safe? When it's really also about sort of the empathy for other people that may not be safe and you don't know that.
Deborah.
All right. I like following Andrew. He's fired.
I know.
So I would say from the perspective of sort of epidemiology and health equity and, community and community engagement, I think from the epidemiologic perspective, there's still so much that we don't know, and epidemiology is formed by everything from preclinical to clinical, all of that. And so we're learning. And so my big concern is that, and there was this talk, and it's so funny talking to people about herd immunity. I'm on the radio every morning and people are like, why don't we just do herd immunity? Let's just get herd immunity. Like, and I'm trying to explain to people, it's sort of like a phenomenon. It's not like we can't do it unless we all just take all the known cases and whatever, and we all just like hang out and make out and, share Kleenexes and all that, right? Which of course I would never advocate for, but we're still learning. And I do think we have a moral and an ethical imperative while we're learning to stay safe. The best thing that we can do is prevent infection. That's the best thing that we can do right now. And I don't pretend that doesn't come with a lot, but the best thing that we can do, in my opinion, is prevent infection.
Christina.
Sorry, those are my kids. Wait, I have one more point to make.
No, I'm sorry. Go ahead, Deborah.
They were like goofing off in the background. Welcome to working
exactly
with kids. And so then the other thing is, I know. So I think we need to give a chance for medicine, public health, and science to catch up. And then my very last point, and I already said it, but I do think that if we really are interested in reducing disparities, we've got to have some urgency around equity. And I just encourage everybody, and I have this really great paper that I'm working on. It's a very simple 3-step process. You start by identifying the disparities. And people are like, well, how do we do that? And I'm like, it's real simple. Disaggregate the data. You'd be surprised how much people don't do that. They just put the numbers out. And when you start breaking them down, you see the differences. When you identify the disparity, you then look a little further upstream. And some people don't have the training to go far upstream. I don't care if you go midstream. Look midstream and see if there's any explanatory factors that would give rise to what you see downstream, right? Because that's the way the river flows. And the further you can look upstream, the better. And then you test and develop and implement interventions that match the level of the problem. We often mount and implement interventions at the level of the individual. But we realize, like even with COVID, these early disparities that we saw, the data we have, only about 10% of them turns out were attributable to pre-existing conditions. A lot more were attributable to how people were treated when they came for care than whether or not they came to care with diabetes or hypertension, et cetera. So I think we need some urgency around equity if we're really gonna do our best to reduce disparities.
Yeah, the comorbidity thing is very interesting, and to hear that that number is so low reminds me of the 19th century notions about the deserving poor versus the undeserving poor. And there is this notion that if most of the people who are dying, it's a comorbidity, there is that has actually caused their death and not simply COVID, then you can sort of feel like, well, COVID's not really the problem. In fact, there's this person had another illness, and therefore I'm not really responsible for whatever it is that has caused higher levels of coronavirus in their communities.
Yeah.
Thank you, Deborah. I've really enjoyed these conversations and really appreciate this opportunity. Christina, your last of the three. Nigel had to leave for another obligation that he found himself with, and I want to make sure to thank Nigel for his input as well. For this whole group, I have not known these four people before, and so this has been really enjoyable. And Christina, you're at the top of the alphabet.
All right, let's do it. Well, I first want to start by addressing your last point, which is this notion that of comorbidity and certain communities having pre-existing conditions that may make them more susceptible to COVID. And I really want to point to some of the historical problems with that. Even as someone, my original PhD is in literature, I moved a long distance from that. But in literature itself, people who were ill, all the way from medieval literature to contemporary literature, it was often associated with some sort of behavioral discrepancy, right? We have a historical narrative in our country about people who are ill being somehow, quote, worse in our mind's eye or worse in our culture. And I think we really need to reassess that evaluation as we think about things with COVID. And that's just one of the types of disparities that we've talked about tonight. There are many others. For the average person who isn't a scientist, I'm not a scientist myself either, I would say one of the best things we can do is try to address some of these inequalities in our own communities in any way we can. Deborah said, and I thought it was really great, I don't care if you make it all the way up the stream, get midstream, do something rather than nothing. If you hear a story of someone saying, I feel like there's a disparity in my life from a group that you know is historically marginalized, or that you've heard is historically marginalized, but you'd like to read more about, take them seriously and do some reading and look into that as much as you can. And there are great charts online about credibility of publications, particularly for things like journalistic sources. So you can look at those charts. You can use a site like Snopes.com to double check and make sure you're getting access to good information rather than misinformation. And listen to people's stories. People often are bursting to tell others about their stories, and they're really held back more because of fear or fear of judgment than anything else. And so if we can reduce those barriers, that's one of the most important things we can do. I'm going to go back to one of the things I started with, which is we want to make sure that we're not leaving out that segment of the population, that piece of data that would really help us develop more innovative, more ethical solutions. And when we start to listen to other people, when we start to put them in positions of power, when we start to acknowledge their expertise, their credentials, their amazing innovative knowledge that they can offer, then that is when we start to break down those barriers and we really can take action. Because I truly believe we will not be able to eradicate coronavirus without addressing some of these disparities, because they're part and parcel of the same thing. And we know, or those of you who follow climate change facts know that these kinds of incidents, disease, natural disaster, both happening at the same time, those things are only supposed to happen more and more frequently. So if we don't address these issues, we're going to be faced with them again and again in more and more severe circumstances. So it's a great time for us to jump in and start now.
Thank you, Christina. Thank all of you. I also want to thank the audience, all of you who joined us, peppering us with questions and comments as we've worked our way through, have really shaped this conversation in very positive ways. I'm going to write a check that I can't cash for Andrew, Christina, Deborah, and Nigel, and say that all five of us work for a public land grant institution. We firmly believe that we have a commitment to something much bigger than ourselves and our own CVs, our own bibliographies. And so I would encourage anybody who wants to reach out to any one of us about the things that we talked about tonight. Our emails are easy to find, and we would be happy to have opportunities to engage in any other way. I want to thank IQ and my friends in the Bioethics Center at Michigan State for helping host this. Thank you all. And again, thank you to all the attendees for joining us this evening. Good night. Wash your hands and wear a mask. That's our best bet at this point. And go green.